Hello, everyone. My name is Michael Sim. I am a head and neck surgical oncologist at Indiana University. Thank you for inviting me. I will be talking about HPV-related oropharynx cancer, an overview for HPV providers. I have no disclosures. Objectives of this talk are to give an overview of transoral robotic surgery. We will also talk about the epidemiology of HPV-related squamous cell carcinoma of the oropharynx. We'll talk about prognosis, treatment options and outcomes, and the role of transoral robotic surgery, also known as TORS, in the era of HPV-positive oropharynx cancer. We'll talk about TORS outcomes and also future directions. Transoral robotic surgery has its advantages of increased range of motion and improved access and magnification. The newest platform is a da Vinci SP, also known as a single port, shown here with these diagrams. This is an intraoperative example of transoral robotic surgery that we are performing. I'm at the console, my assistant's at the bed, and this is the contraption. This is intraoperative photos of our team, just highlighting how important teamwork is in the operating room. Oropharynx, what does that mean and what do we see there? Squamous cell carcinoma is the most common pathology, followed by salivary gland malignancies. There is lingual tonsillitis, lingual tonsillar hypertrophy, as well as benign masses we see as well. This is the anatomy of the oropharynx. You can see it's bordered by the soft palate, anterior tonsillar pillars, and the base of tongue outlined in red. On the next slide, this is a posterior view with a tumor as an example of the area that we treat. You can see that it's fairly far down, right above the epiglottis, and hard to access through the mouth without robotic technology. Oropharynx cancer background. The incidence of oropharynx cancer appears to be rising despite an overall decline in head and neck cancer due to decreased smoking. But due to the increased incidence of HPV infection, the incidence of oropharynx cancer is rising. And as of several years ago, the annual incidence of HPV oropharynx cancer has surpassed the annual incidence of cervical cancer. Interestingly, the most common presentation for patients with oropharynx cancer with HPV is not throat symptoms, but a neck mass, evidence of metastatic disease to the neck. As you recall, HPV is a double-stranded circular DNA virus, and it replicates exclusively in the keratinocytes. The E6 and E7 viral oncogenes are what promote the cell growth by inactivation of P53 and the PRB gene. The high-risk subtypes that cause cancer are type 16 and 18. HPV 16 causes more than 90% of HPV-positive cancer in the head and neck. Gillison et al. Showed that 26 or more vaginal sex partners or 6 or more oral sex partners dramatically increases the risk of having HPV-related cancer. There is a difference in patients who have head and neck cancer from HPV versus those caused by smoking and drinking. In short, patients who have HPV-related oropharynx cancer have better disease-free survival and overall survival compared to those who have the same oropharynx cancer site but caused by smoking and drinking and not caused by HPV. Oncologic outcomes were shown by Ang et al. In a follow-up study to the RTOG 0129, where they showed a dramatically increased overall survival with HPV oropharynx cancer at 3 years, being 82%, for example, versus 57% for HPV negative cancer. Progression-free survival was significantly higher, and recurrence rates were dramatically lower in HPV positive cancer at 13% compared to 35%. So you see here the clear difference in profile of prognosis and outcomes when you compare oropharynx cancer caused by HPV versus HPV negative. These just diagrammatically show the difference in the survival curves. You can see how there's a clear separation in HPV positive disease versus HPV negative disease in survival. And we did see that with smoking, it does convey some amount of negative prognosis, but still patients who have HPV cancer but who smoke do better than patients who have HPV negative oropharynx cancer. So what are the treatment outcomes? If you look at the NCCN guidelines, there are multiple routes to treating patients with oropharynx cancer. You can have radiation, alone, or you can treat it with radiation and chemotherapy. You can also treat with surgery. And there are many different variations where you can also add induction chemotherapy. Some of this is institution dependent. Some of it depends on what protocols are set in your treating facility. There was a time, decades prior, where radiation and chemotherapy was not known to be so effective in head and neck cancer, and so surgery was the prevalent treatment. But with many keynote trials showing the effectiveness of chemotherapy and radiation with head and neck cancer, the paradigm shifted for most of these patients to receive heavy chemotherapy and radiation. The landmark study, the Veterans Affairs, for example, laryngeal cancer study trial, showed pretty high effectiveness with chemotherapy and radiation, as well as the RTOG 9111, which helped shift this paradigm from surgery to concurrent chemotherapy and radiation. Non-surgical treatment includes usually 2 gray fractions of radiation over a 7-week period for a total of about 70 gray, with concurrent or same time treatment with cisplatin as the chemotherapy regimen. And for those who have disease after radiation and chemo, there is salvage surgery that may be needed. Obviously, there are concerns, though, with chemotherapy and radiation due to the toxicity profiles, including loss of taste, dry mouth, also known as xerostomia, need for feeding tube and trouble swallowing, also known as dysphagia, febrile neutropenia, radiation dermatitis, and pain. Severe late toxicity after concurrent chemoradiation therapy is a major concern with chemoradiation, as McTay et al. Showed with analysis of 3 major trials, showing that 43% of accessible patients had severe late toxicity. 35% of these patients in the studies were oropharynx cancer patients. They found increased toxicity associated with older age, advanced T stage, and those with larynx and hypopharynx as primary sites. But obviously, traditional surgery also has its concerns. The traditional approaches to the oropharynx are, pretty morbid, with a mandibular swing approach, also known as a mandibulotomy, or pharyngotomy, where we open through the throat muscles after making neck incisions. These are very effective approaches, but can be very morbid, which is why patients' treatments were shifting towards chemotherapy and radiation. The function after these open approaches could be poor, and therefore, despite the toxicities related with chemotherapy and radiation, the functional outcomes seemed to be better, which shifted again the paradigm to chemotherapy and radiation. Transoral laser microsurgery was an option, which conferred lower morbidity, but was a technically more challenging technique. Superior oncologic outcomes, though, with upfront surgery were known, as a landmark study from Head and Neck published in 2004, looking at 16,000 cases, showed that early stage disease, surgery with or without radiation, had higher survival than those patients who got radiation alone. And with advanced stage disease as well, patients who had surgery with radiation to follow had the highest survival. So we knew all along that if surgery was possible, it would be a great option. These are the curves showing those benefits of being able to do surgery first in early stage disease, followed by advanced stage disease in these curves here. Then came the advent of transoral robotic surgery. As you can see in this diagram, again, this is the contraption by which we expose the oropharynx and we position the robotic arms. Robotic surgery was first described by the group at Penn in 2005 and was finally FDA approved for transoral robotic surgery in 2009 for T1 and T2, so early stage tumors. As I mentioned earlier, NCCN guidelines did recognize transoral surgery as a useful modality for treatment in these patients. And so with TORS, candidacy is important if we are going to offer surgery to these patients. Again, T1 and T2 tumors are what FDA approval is given for. We try to select patients where we can preserve much of the soft palate, because again, the goal is to preserve function and not just provide cure. We also want to be able to save as much of the base of the tongue and as much as the posterior pharyngeal wall as possible when we do surgery, again, to cure but still provide excellent functional outcomes compared to chemotherapy and radiation. Early stage disease is ideal, that we classify as T1 to T2 and N0 to N1 or N2 even. Generally, these patients have good outcomes no matter the modality. Again, the goal is to achieve optimum oncologic outcomes while minimizing the acute and late toxicities. With modern radiation techniques like IMRT, intensity modulated radiation therapy, severe late toxicity is decreasing, however. So really the approach that you take, whether we offer chemotherapy and radiation versus surgery, depends on, for early stage disease, multiple factors. Pre-op patient selection that factors in is, for example, their smoking status. There can be concerns of decreased radiation efficacy with smoking, and so perhaps that would push us to offer surgery more aggressively. If they live far from a distance for radiation, and therefore the one-time treatment of surgery could be attractive for those patients. If the patients have had previous radiation for other cancers, that would make re-irradiation difficult. Poor social support and non-compliance could also be factors that play into which treatment route we recommend for patients. Tumor factors are important. As I mentioned earlier, T1, T2, so small exophytic tumors with minimal deep invasion, those are ideal for transoral robotic surgeries because we want to achieve negative margins, meaning clear the disease, and still preserve good functional outcome. These are photos of and CT scans as examples of those who have poor candidacy for transoral robotic surgery. In the picture on the top left, you can see the tumor occupies most of the left oropharynx. And so even if it's resectable, we would not be able to leave as much functional tissue behind, and thus patients could have poor function. And in these patients, we think that the chemotherapy and radiation, despite its toxicity, could be better than what surgery would do. The CT scans show examples of, again, of other reasons for poor candidacy, including neck disease that is too aggressive and is too close to the primary in the throat, which would create an opening, a communication between the throat and the neck. The other example here on the right is a CT scan showing a patient who has an internal carotid artery that is in an aberrant location right behind the tumor, and that would risk injury to the internal carotid artery during surgery. So these are just examples of how selection is important when offering patients TORS. Here's a example of a radical tonsillectomy, also known as a lateral oropharyngectomy, for a patient of mine who had tonsillar squamous cell carcinoma. You can see how we make the initial incisions. This is a robotic view, and we enter deep to the superior constrictor muscle to get an adequate margin. This photograph is showing the example of a base of tongue tumor. And again, this is an area that is difficult to access through the mouth without the aid of robotic technology due to how deep and inferior it is located. So what are the oncologic outcomes of transoral robotic surgery? In this study of retrospectively looking at 410 patients who underwent TORS, 31% of patients underwent radiation therapy alone, 21% received radiation therapy with concurrent chemotherapy after surgery. The mean follow-up was 20 months, and they found excellent oncologic outcomes, including local, regional, and distant recurrence rates of less than 5%, 4.4%, 3.7%, and 2.4%. And 4.1% of patients died of disease. So excellent oncologic outcomes. 2-year local regional control rate, therefore, was 91.8%. Disease-specific survival was 95%. Overall survival was 91%. So again, compared to the HPV negative counterparts, these are excellent outcomes. The interesting study conducted by the Penn group also showed in their prospective trial of 30 patients undergoing TORS and neck dissection, found 1 recurrence despite only undergoing surgery without any adjuvant radiation or chemotherapy. So again, highlighting the efficacy, high level of efficacy, I should say, with surgery. What are the functional outcomes like for those who undergo TORS? In this study, again, a 1-year and 2-year analysis of patients undergoing TORS, 0% of patients required a G-tube long-term. In this study that looked at prospectively in a non-randomized fashion, 40 patients with stage 3 or stage 4 oropharynx or supraglottic cancer were included. In group 1, patients underwent TORS and adjuvant therapy as indicated. In group 2, they were non-surgically treated with chemotherapy and radiation. And patients were assessed using the MD-ADI dysphagia index. In this study, no statistically significant difference was found at treatment or at the 3-month follow-up visits. And at the 6-month and 12-month visits, there was significant difference seen in those two groups. Adjuvant therapy with TORS is allowing for dose reduction after surgery by reducing the radiation from 70 gray to 60 gray, and this provides less acute and late toxicity. There are other trials going on right now, for example, the ORDO trial, that is trying to further lower radiation dose, and we are conducting a trial here as well at IU, Indiana University, to de-intensify therapy if possible for select patients. So how does de-intensification work with surgery? In short, the surgery allows for the reduction of the volume of tissue that needs to be radiated. And these are slides courtesy of Dr. Harry Kwan, where we can see, for example, without TORS, the darker red oval shows the area of radiation and then the collateral radiation damage. But with surgery on this next slide, you can see the significant reduction in the area of dark red, showing the allowing of reduction of the radiation field after surgery. And also the collateral radiation decreases as well. And so, in short, less tissue is radiated, less scarring, less toxicity, and better function long term by allowing us to de-intensify or reduce the amount of radiation, and also to obviate the need for chemotherapy after TORS. Where the robotic technology also is highlighted is in the setting of the unknown primary, where we find squamous cell carcinoma in the neck, metastatic to a lymph node, but we don't know where the primary started. Prior to robotic technology, many of these patients would undergo chemotherapy and radiation in a wide field in their throat, knowing that it came somewhere in the upper aerodigestive tract. But now, with robotic technology, we are able to perform extensive biopsies. In this photo, we can see all the tissue that was removed in a superficial fashion for us to identify the primary. And so now our detection rates are close to 90% for these unknown primaries. And that allows for drastic reduction again in radiation and thus overall better function for these patients. Some final notes is the importance of HPV vaccination. Is there a way to prevent this cancer since it is virally driven? And the answer is yes. As we mentioned, HPV incorporates into the E6 and E7 oncoprotein for it to provide carcinogenesis. And so if we can block the integration of HPV into the DNA, obviously that would prevent cancer. And so HPV vaccination has been shown to be very effective to prevent HPV infection, theoretically lower the rates of HPV-related cancer moving forward in the future. Markowitz et al. In the Journal of Infectious Disease in 2013 showed that rates of HPV infection targeted by vaccine fell from 11.5% in the 2003 to 2006 period to 5.1% after 2007. And from the 79 million doses of Gardasil distributed since 2006, less than 0.1% have had a reported serious adverse event. So this is an important note to provide to patients and patients' parents if they are pediatric. There are many right now that are concerned about vaccinations, the adverse effects of it, but really the data shows that it is very safe and can help prevent HPV, not just infection, but cancer for these patients in the future. The paper published by Herrero et al. Also showed a 93.3% efficacy for vaccination. So it is to be highly encouraged, especially by our primary care providers. What are the future directions? There are many ways that we are trying to see if we can treat patients by decoupling the primary and the neck, meaning separating the radiation fields. We're trying to see if we can reduce radiation doses further. We're trying to see if we can spare radiation to an entire side if possible. So there are many strategies going on right now. Here are some example videos of a base of tongue transoral robotic surgery operation. You can see the exposure. The video shows this to be two-dimensional. But for us surgeons sitting on the console, the advantage is that it's actually three-dimensional with a binocular view, which is incredible for mapping of the tumor spatially as well as magnification. And again, as I emphasized earlier, this is an area that would not be possible to access transorally without the angled instrumentation abilities of the robot. You can see the cuts being made. You can see the identification of a vessel that allows for vascular control with vascular clips. And here are the final cuts deep and inferior within the oropharynx, right above the epiglottis. Next video here is another site and a patient who has palatine tonsillar cancer. So you can see the lateral cuts being made with the robotic arms with what we call a bovie or monopolar cautery. So it cuts and coagulates. We are going through the constrictor muscle here to provide an adequate deep margin. This is further lateral work deep to the tumor. We're always conscious of taking enough tissue to achieve a negative margin, but still leaving behind enough functional tissue so that we can preserve excellent function. And so again, this highlights the importance of patient selection, because we want to find the patients who we can confidently perform surgery to adequately remove the tumor with negative margins, but still preserve good function by leaving behind enough tissue for good swallow. These are the final cuts being made inferiorly. Again, an area that can be difficult to see without the robotic magnification and access. These are the final cuts to remove the tumor. Our final slides show the treatment de-intensification trial that we are running here at Indiana University, where we are performing transoral robotic surgery, followed by observation for 4 or 5 weeks of radiation, depending on patient's pathology and risk stratification. And we are obviating the need for chemotherapy for patients enrolled in the trial. And thus far, results have been very successful with improved toxicity profiles, improved function, despite the de-intensified therapy. So conclusions are that HPV oropharynx squamous cell carcinoma patients are younger, healthier, non-smokers. TORS is a safe and effective treatment method and is at least equivalent to non-surgical treatment via chemotherapy and radiation, many times a better option with good functional outcomes. As I highlighted before, careful selection is key, and with surgery, late toxicities and side effects from chemotherapy and radiation may be avoided or reduced, especially with the de-intensification strategies that will continue to shape the future of treatment paradigms in patients with HPV oropharynx cancer. Thank you very much.